Today let's learn use of hot snare in bronchoscopy and use of hot snare for resection of endobronchial tumors, like in this 35-year-old patient who was referred to me for bronchoscopic resection of a large pedunculated tumor near the carina. The tumor is attached onto the anterior wall and the peduncle is very broad. It's nearly like 25 millimeters or 2.5 centimeter attachment. And why hot snare in this patient is, as you can see, a lot of collaterals, and we anticipate moderate to severe bleeding in this patient. We can discuss or debate on whether we embolize these cases, but we usually don't. And it's very important when we make a plan to use hot snare in the airway to read the CT scan in all the three planes, because sometimes when the tumors are too large, and then as you can see here it's touching both the sides, both the walls, you sometimes never know where exactly the stalk or the peduncle is. So it's very important to read, and we don't have the issues of counter burns when we use hot snares in our pulmonology, but I don't know if that exists, that concept, because we never talk about it. But I think in this case, since the posterior wall is attached, maybe I invite your opinion on the counter burn concept in this patient. And when we use a snare, hot snare, it's very important to select the snare based on the type of the lesion and the length of the lesion. Here I use a Cook jumbo acute snare. The idea is to loop the whole lesion en bloc rather than trying to cut into pieces, because if you do that in this patient with these vessels, like you take a long time to control the bleeds. And then when we talk on hot snare in endoscopy, in bronchoscopy, we always have to decide on what settings. Here I use an endocut Q mode with an effect of 4 maximum, and cut duration of around 2 seconds, and cut interval around 5. But that's operator dependent. Everyone uses their own preferred settings. And then once I cut the tumor, and always rigid bronchoscopy is in place in this case, and the tumor is detached, and it seems to be larger than the lumen of the rigid bronchoscopy. So we make a plan to remove it en bloc rather than trying to get it through the barrel of the rigid bronchoscope. So I try to use a 1.7 millimeter cryoprobe, but because of the bleeding, my vision is not maintained. So I just come back, clean the blood around the lesion, and then pass a 1.7 millimeter cryoprobe through the working channel of the bronchoscope. And sometimes it is important to stop ventilation at this point if the anesthetist is bagging, the blood keeps spilling back. Once the cryoprobe is attached, we remove the tumor en bloc with the rigid bronchoscope, and then re-intubate the patient using a rigid bronchoscopy. So in this case, I encountered a problem, like you can see, following resection, a large vessel on the anterior wall above the carina starts to bleed. And then the problem with any form of hot applications to control bleeds in bronchoscopy, unlike endoscopy where they have two different working channels, we only have one working channel. So it's sometimes very difficult when the lesions are actively bleeding and then you have no suction. So we use some imaging modes here, but still not very successful in controlling the bleed because of its active nature and the volume is too large. So what we decide is like use the tip of the rigid bronchoscopy barrel to tamponade the bleed, and once we tamponade, still you can see some margin is out there. So I just advance the barrel a little forward and then apply pressure on the anterior wall to make sure the bleeding is controlled or minimized, at least until I finish cleaning the airways. Once I confirm the tamponade is having a good effect, after 15-20 minutes I had to use around 15-20 minutes of pressure here in this case, and then slowly when I pull back the barrel, we see that the bleeding is controlled. So sometimes the most effective methods is using the barrel itself, and a small portion of the tumor is left, and then we fire APC at the base. We don't have a pre-biopsy diagnosis in this patient, so we combine biopsy and resection as a single procedure, and depends on the histopathology. We decide whether we go for resection or put him on a close follow-up. Even if patients are for resections, a bronchoscopic clearance sometimes will help the surgeons to have a better understanding, and even it helps the anesthetist to put the tubes, especially in those tumors very close to the carina. And then once the bleeding is stopped now and the APC application is completed, now you can see the lesion on the anterior wall and appreciate the base of the lesion. So today's case explains the importance of a hot snare application in bronchoscopy.